Good morning. Myself is Mrs. Lakshmi K, M.Sc Nursing, Associate Professor from ES College of Nursing, Visolai. Today, I am going to discuss about the topic post-maturity. So, what is post-maturity? Post-maturity is a term used to describe a baby born after 42 weeks of pregnancy. It is also called post-term, post-dated, or prolonged pregnancy. Here, the assessment of fetal well-being is very important in order to avoid stillbirth, IUD. Yes, we have to move on to the post-maturity definition. So what is post-maturity? Literally any pregnancy which has passed beyond the expected date of delivery. But for the clinical purpose, a pregnancy continuing beyond 2 weeks of expected date of delivery. That is, usually the pregnancy period is 280 days. If it goes beyond 2 weeks, that is 14 days, 294 days, then we call it as post-maturity or post-dated pregnancy. What are the causes for post-maturity? So the most common cause for post-maturity is wrong date, that is inaccurate calculation of LMP. That is last menstrual period, first day of last menstrual period. If it is calculated wrong, then we consider post-maturity problem may arise. Second one is biological variability, that is hereditary. If the family have the history of post-maturity, there is a chance for getting in the present pregnancy. And third one is maternal factors. Here primiparity is one of the major cause for post-maturity. Then second one is elderly multipara. The mother who has given 4 or 5 birth and again she is continuing is more risk for post-maturity. And third one is sedentary habit. Nowadays, once we become pregnant, our family members are most instructed to take complete rest. Not only family members, doctors. That is also leads to post-maturity. And next one is previous prolonged pregnancy. Previous history is there also one of the cause. And next we move on to the fetal factors. Here the fetal factors, congenital anomalies, that is anencephaly is one of the major cause for post-maturity. Why? How? What is anencephaly? It is nothing but underdevelopment of brain and incomplete formation of skull bone. So because of that, the abnormal fetal hypothalamo-pituitary adrenal axis, you know very well, for initiation of labor, hypothalamo-pituitary adrenal axis is very important. Adrenal gland plays a major role to produce cortisol. So if there is anencephaly, the reduction of or production of fetal cortisol is reduced. So automatically there is no initiation of labor which leads to post-maturity. And next we move on to the placental factors, that is sulfatase deficiency which leads to low estrogen production. The estrogen also plays an important role in initiation of labor. Because of low estrogen, there is post-maturity occurrence. And next we move on to the diagnosis. Here the menstrual history is one of the important thing to calculate, to identify post-maturity. Mother, if she is sure about her previous history of regular cycle, then if she is having any lactational amenorrhea or immediately withdrawal of pill, the confusion may arise. In such condition, we have to verify her previous well-documented antenatal records of first visit in first trimester, which will be helpful. And next we move on to the clinical findings. Of course, the clinical findings plays a major role in identifying post-maturity, that is weight record. So regular checking of weight of the mother, that rules out whether the weight is not increasing, that is stationary, or it is falling down, that can be identified. And second one is abdominal girth. So as we know that once the pregnancy beyond expected date, there is a decrease of liquor. So automatically the abdominal girth also will be reduced. And third one is falls of pain. False pain will be there. That will be relieved within short period. That is indicative of post-maturity pain. And next one is abdominal palpation. So here the findings taken together are helpful, like height of the uterus, size of the uterus, hardness of the skull bones, and decreased liquor amni, and uterus feels full of fetus. Height of the uterus. How the height of the uterus plays a major role in identifying means automatically the height of the uterus, that is symphysis of fundal height, will be reduced because of reduced amniotic fluid. Same way size of the uterus is also reduced. Then hardness of the skull bone occurs because the moldings takes place in utero itself. Because of that, the decreased Leica ramni, the uterus is full of fetus when you palpate. Then internal, when you do the PV examination, when the cervix is ripened, not ripened is nothing but softening of the cervix, Guru signs are appeared, then that indicates fetal maturity. If it is unripened cervix, that does not exclude maturity. Then feeling of hard skull bones indicates the maturity. And next one is investigation. Of course, the investigation is very important to rule out to prevent the complication of post-maturity to the mother and the baby. First, to confirm the fetal maturity. So, whenever we are taking the management for normal spontaneous induction or for cesarean section, we have to confirm the fetal maturity. And second one is to detect the placental insufficiency, whether there is placenta is having any problem in circulation to the fetus. Investigation is confirmed through sonography. And amniocentesis, it is an invasive procedure. Most it is not preferable, but in some condition it may be used. Amniocentesis is nothing but aspiration of the amniotic fluid and biochemical markers are identified. And next one is assessment of fetal well-being. So how we can assess fetal well-being mean NST, non-stress test, that is fetal heart rate followed by fetal movements will be assessed twice in a week. And biophysical profile, USG, especially in USG, amniotic fluid index is assessed. Doppler and clinical findings plays a major role in identifying the fetal well-being. So clinical concept, once the baby is born, by the appearance, by physical appearance, we can able to say whether this is a post-mature baby or not. Like skin is wrinkled and old, and nails, long fingernails and toenails are seen, hair growth is more, creases are seen more in the soles and palms, and vernix caseosa is absent. This vernix caseosa is very important in baby to prevent or to protect from infections and chillness that lacks here. And next head is there is no without evidence of molding because already it has happened. Then the skin will be green, brown or yellow in case of meconium stained. Alertness, the baby is very alert and wide-eyed, and weight is more than 3 to 4 kg, that is called macrosomic baby, plump baby. Then length above 54 centimeter. Then Leica ramni is very scanty, very little. After post-maturity, that is post-dated, the Leica ramni 1000 ml, it has been reduced as the pregnancy goes, and it comes 200 ml also. So the scanty or stained with meconium. Placenta, when you inspect after delivery of the placenta, there is aging of placenta, evidence of infarction and calcification. Then cord, diminished Watson jelly. So it is a friction will be avoided in the cord. If it is diminished, automatically the cord compression may occur. So the circulation to the fetus will be curtailed. So the mother to fetal circulation is affected. And next, complications. So during pregnancy, diminished placental function, oligohydramnias, that is decreased amniotic fluid less than 200 to 400 ml, meconium stained liquor, fetal hypoxia may occur. During labor, fetal hypoxia, meconium aspiration, cord compression, shoulder dystocia, risk of birth injuries. So after birth, what are the complications may arise for the baby? Macrosomic baby, chemical pneumonitis, atelectasis, collapse of the lung alveoli may occur, pulmonary hypertension may occur, hypoxia, hypoglycemia. So we have to be very careful. Hypoglycemia is a major complication. Then polycythemia. Then risk of neonatal convulsion. So next we move on to the management. Here already I said once you are deciding for management, you have to confirm the maturity of the fetus and you have to be very careful in fetal surveillance twice weekly, and timely delivery is important to reduce the risk of stillbirth. Here the management is grouped into complicated cases and uncomplicated cases. So here uncomplicated, when it is called uncomplicated means the pregnancy is continued till spontaneous onset of labor, that is selective induction can be given. Routine induction, if the pregnancy is continued beyond the expected date of 7 to 10 days, they will be giving for routinely induction for the mother to deliver. Here uncomplicated, again it is favorable cervix and unfavorable cervix. So favorable cervix is nothing but, already I said, the ripened cervix is the favorable cervix. In that condition we can do stripping of membrane, low rupture of membrane. When the liquor is clear, then we can administer oxytocin. If suppose the liquor is not clear, whether it is useful to wait for by administering oxytocin? No, the fetal will go for hypoxia and IUD stillbirth may happen at any time. So we have to decide for immediate cesarean section. So unfavorable cervix. Unfavorable cervix, the cervix is not ripened. In that condition what we have to do? We have to make the cervix to ripe. So in that we have to use vaginal prostaglandin E2 gel to ripen the cervix. Followed by that we have to do the lower rupture of membrane. Followed by that oxytocin infusion is added. Next, if the mother is complicated, when she is already having some high risk, who are all comes under high risk? That is elderly primigravida, preeclampsia, that is the patient is having BP, proteinuria, all those things are there. So in that condition, oligohydramnios, amniotic liquor is very less, and RH incompatibility. So we have to plan for elective cesarean section. Next we move on to the management, care during labor. Here labor is prolonged, especially due to macrosomic baby and poor molding of the head. Then analgesia should be given because the mother is having a prolonged labor, staying, she become tired and she will have more pain. In that condition we have to give, no way to avoid pain. So in that condition we have to administer adequate analgesia. If there is a possibility of shoulder dystocia, we have to do the maneuvers, Robert maneuvers, and careful fetal monitoring. Even we are tried for normal labor, if the baby is fetal distress, we should not, FST, that is fetal heart rate, should be noted. If there is a fetal distress you identified, then immediately emergency CS we have to do. If not, forceps or ventos, based on the patient baseline we have to decide the management. No wait here. Thank you.